Welcome to everyone who's participating today in this workshop at the German DRR conference. I hope everyone can hear us. The title of today's workshop is Urban Preparedness for Emergency Response, with a specific focus on mass casualty events in cities, and from different perspectives, from three different perspectives today here in the workshop. My name is Isabelle. I work for the German Red Cross, still in the capacity of a regional focal point for the topics disaster risk reduction and urban in the Middle East and North Africa, based in Beirut. Soon I'll be taking over the German Red Cross Head of DRR unit in the headquarters in Berlin. I will be facilitating this workshop today with my colleague Thomas. Thomas, over to you for a short introduction.
Hello, thank you very much, and also welcome from my side. My name is Thomas Marcik. I'm working for the German Red Cross headquarters for urban humanitarian work unit, and I'm very happy to have all of you joining us today for this panel, and you as core resource persons, I'm very happy. Back to you, Isabelle.
Thank you, Thomas. We have a panel today of three different speakers. We have 90 minutes time to hear their presentations first, and then we will have time for a discussion round, which Thomas will facilitate. This workshop is live streamed, so you can post questions in the chat below, and we will try to answer your questions that you're posting in the chat as much as possible. So please feel free to contribute to the discussion while we are presenting, and also later on during the discussion round. But before I'm introducing our speakers, I would like to take you on a short journey in order to actually introduce the topic of today, emergency preparedness in cities. Imagine a city with thousands of people living in the city, busy streets, cars everywhere. It's during the day. Maybe it's rush hour. Maybe people just finished their work, are going home, making plans for the evening. And then something is happening in the city, something that actually disrupts the life quite sudden and quite fast. People afterwards will say that this was so unexpected. The unimaginable happened. Something happened that they would never imagine that it's happening. But let's go back to the moment the incident is happening. Just a few seconds afterwards, imagine emergency service hotlines that receive calls from everywhere in the city, from every part of the city. People need help, and the dispatchers can actually put the puzzle together and say where it's coming from, what has happened. The bigger picture is missing. Imagine an ambulance service that is rushing to different scenes in the city. Not knowing what to expect, and maybe unable to take everyone. Maybe an ambulance service provider and a volunteer has to say no to people who are wounded. Imagine a hospital in a city that is partially destroyed and needs to function in that moment. Imagine that the people that are in the hospital already before the incident need help. Imagine that people are arriving at the hospital and it's chaos everywhere. Imagine doctors, nurses, volunteers of organizations, paramedics, firefighters, civil defense, officials from the city, everyone basically who is needed for a functioning city, and the list is long of these people. Imagine they are affected themselves, and imagine they can't actually access their work anymore. I know what I just said sounds quite like a terrible scene from a movie, but unfortunately this has been reality in the past decade in cities around the world. You as the audience, you will all remember images from 9/11, from recent incidents in European cities, for example, from Paris 2015, or more recently, the Beirut port explosions in 2020. All of these incidents are quite different, and we will hear from very different incidents today from our speakers. But what they have in common is that the impact and the scale, it's hard to believe the impact and the scale of these incidents. And even experienced frontliners, such as an emergency medical service provider, will tell you that they haven't experienced that before. In recent debates about responses in urban settings, often you will hear that cities are very complex in itself. Now imagine the complexity of a mass casualty incident with multiple sites involved within one city. And this actually sounds truly like a worst case scenario and a nightmare for preparedness efforts and for the emergency response management itself. And this is why I think our session today and also the continuous work of our speakers and others who are involved is so crucial to respond that question, whether it's actually possible to prepare for such worst case scenarios. I think we can already all say, yes, it is possible, but it's quite hard work. It's joint effort. It's continuous efforts on preparedness, on institutional preparedness with a lot of stakeholders involved. And the how, so how this can work, this is what we're going to hear today from our speakers, from theory to practice, from their incident management experience, and also the lessons that they made from recent incidents for future preparedness efforts. I would like to introduce now the panel first, the three speakers before we start. Our first speaker is Dr. Junaid Razzak, who is the Vice Chair at the Department of Emergency Medicine at Weill Cornell Medical College. He'll give us an introduction into an assessment tool and research that can be used to identify the capability of a city to respond to a mass casualty incident. Our second speaker is Monsieur Philippe Testat. He's the head of the Health and Disaster Risk Reduction Department at the French Red Cross. He will present us learnings from recent incidents in European cities, for example, from Paris. And our third speaker is Dr. Shawky Eddine, who is from the Lebanese Red Cross. He's the Director of Learning and Development. He's also the Assistant Director for Training and Quality in the EMS of the Lebanese Red Cross, and he's the COVID-19 Response Coordinator. He will be talking about the Beirut port explosions incident management, but also the findings from a recent real-time evaluation that we did together with him after the Beirut port explosions. He was also the incident command manager in the night of the Beirut port explosions. With no further ado, I would like to hand over now to our first speaker, Dr. Junaid Razzak. Over to you.
Thank you so much, Isabelle and Thomas, for this opportunity, and of course, the German Red Cross. I'm going to share my screen and see if that works. Can you see my screen? Great. So I'm going to be speaking about a project we finished a few months ago. And that comes from, as Isabelle said, our joint experience, but my personal experience of running an EMS service in Karachi, Pakistan for several years and heading an emergency department of a hospital. And during that time, we were unfortunately experiencing a lot of mass casualty events, terrorism and other disasters, and realized that it is not just a medical problem. For us, it was a big change. For those of you who work in other areas, it probably was not. And the problem at that time was, how do you, what is the system and how do you measure that? And that's the discussion from the mass casualty perspective. My talk is going to be in these four areas. And Isabelle has already said that groundwork of why cities and emergency response. I'm going to talk about our approach and framework for the work we have done, the findings. I'm going to share with you findings from one city, part of the findings because the time is short, but you'll get a sense of what kind of output we are looking at. And finally, we'll talk about the proposed way forward. Now, why cities? Of course, cities are the backbone of the economy. The number of people living in cities are going up, and most cities, unfortunately, are much more vulnerable to multiple disasters, or at least one type of disaster. And again, this picture identifies those cities and the risk of natural disasters and other types of disasters. Also, we have all unfortunately seen cities and everyday risks, bombing events, typhoons, the building collapse, and then terrorism, of course, multiple car vehicle accidents, and then fires, and many more. So this is what we are going to talk about, is going to address unfortunate events that are happening every day. And the question we were trying to answer was, how well are our cities prepared for mass casualty events? And when you ask that question, you get different responses, right? And the responses that I have experienced, and I'm sure you also have, is a lot of people will say, you know what, we are okay. We are doing well, our system is great. And you say, how do you know? Well, we know. We live here, we know the system is working. And then there are some people who say, we have policies and procedures. I think we're in a good shape. And then some people will base their assessment on some sort of tabletop exercises, and others would have done some disaster drills. And rarely you will see any measurement during an actual event. So the first four are examples of how assessments are done often in the cities, and that leaves a lot of gap. And the gap is what we were trying to fill using a tool that will focus on the key aspect of our mass casualty response. It is focusing on initially on life-saving. We wanted to look at the tool that creates a complete picture and not just, well, how many ambulances do we have, or our paramedics are trained or not, or do we have a number or not? We wanted to create a whole picture. We wanted to capture perspectives from the front line. We wanted that tool to be practical and affordable, and there was a lot of debate around this last point, is to actually have a quantitative score so cities can compare themselves over time and with others. And that was a big ask, and you'll see we are still working on it. And again, specific questions for our study were, can a reliable and valid tool be developed to identify gaps in cities' emergency medical response system? Could a number or summary statistics be produced that will help the city authorities track their own performance over time? And can such a tool be useful for the city leadership? It was not going to be only a research project. We wanted to make sure that we are engaging with the policymakers and learning from them constantly so that we can produce something that is useful to the end user, which is policymakers. And our theory of change was, we're coming from the perspective that you really can't manage what you can't measure. And this is a well-known quote, of course. In the field of disasters, we have sort of skirted away, especially in the field of emergency medical response, we have been skirting away from measurement because we think it's too complex to measure. And that's partially true. Our theory of change was that if cities understand the issues, and if cities can measure their performance, the city leadership will feel empowered, and they will then prioritize system improvement. So this first two blue graphs, the boxes, is what we call CAMERA, the City Assessment for Mass Casualty Emergency Response. This was our attempt to create a tool that will allow cities to understand their issues and measure their performance. And how did we do that? We did extensive review of published data. We engaged with a large number of local, global experts, our colleagues at ICRC. We developed and pilot tested a measurement tool, and then we presented it in a couple of cities, and we learned from the feedback. So, and I'm going to take you through that in a little more detail. The methodology of the development was, as I said, we did literature review, we interviewed key informants and experts, we did a Delphi process to prioritize areas of focus. We then developed the tool, it was reviewed by international study groups. We did pre-testing, testing. Then we went to 2 cities. We were supposed to go to 3 cities. We did the disaster drill, where we had about 100 victims of a disaster drill of a building collapse. And we observed the response in the field during transport and at the hospitals. And we compared that finding with the camera tool, which was basically a questionnaire that we asked the key informants. And then we compared how valid were the 2 answers. And then we presented to the policymakers and we got their feedback on that presentation. And we are in the process of report writing and further thinking about next steps. Our framework, and this is the important slide, I just wanted to take you through this. The framework for the camera tool is, we have 2 major components. First is diagnosis, and diagnosis in terms of what's happening at the city preparedness, city response level, diagnosis in terms of what's happening at the scene of mass casualty events. So scene incident command structure, triage treatment, scene safety, then transport, and then what is happening at the hospital. So 4 components in the hospital: hospital's preparedness, like policies, procedures, hospital incident command structure, triage and treatment, and safety and security. On the management side, we wanted to get some sort of idea on the governance. How can we fix based on the diagnosis? What are the opportunities for the governance to improve? What are the opportunities for command, control, and communication to improve, clinical care to improve, and safety and security? So we took a very clinical physician sort of thinking, medical thinking of diagnosis and management, and we kept the city leadership in the middle. And then, as I said, we did disaster drill. This is a disaster drill in one of the cities where we had right here in the middle, you can see this person. He has a checklist and he's observing, and the few other international and national observers looking at all of these interventions. You can see this person has a paper on him, and that describes what kind of injuries he has. So when he gets to the hospital, we are observing the quality of care based on what kind of numbers and injuries does he have. Again, a few pictures. What does camera tool look like? It is a 6 set of questionnaires with a total of 37 items. It has a lot of questions and some observations. We go and ask these questions to 12 individual roles: 2 EMS leaders, 2 EMS providers, 2 security leads, 2 emergency department nurses, 2 physicians, emergency department leads, and 2 city leaders, those who are involved at the political policy level. 296 of these questions were yes and no questions, and 75 were details and evidence questions. Many questions were similar across roles. Some were specific to those roles, and tools were administered using Qualtrics.
5 more minutes at this moment.
Sure. We did the validity analysis, again, based on the disaster drill and the findings from the questionnaire and the observation during the questionnaire. We then checked whether questions were responded equally by both participants, because as you notice, we asked same questions from at least two participants, if not more. We also check for consistency and logic questions and see if somebody said, yes, we do have triage training, and they say, what kind of triage training do you have? And if you don't know the name, or if they gave some other answer, then we took that as part of our analysis. And we also looked at multiple responders. And this is how we classified our response. If a city did score less than 50%, they had critical gaps, and as the scores went up, they went to major gaps, moderate, minor, and they were ready at a score of 95% or more. These are findings from study city A. And here you can see the scores. First column is all the various tools, all the various areas we looked at, as I mentioned before, the drill score, the camera tool score, and then what classification of gaps did we see in the two, through the two methods, drill and camera. And this is what we presented to the policymakers. Again, for city preparedness score, for example, we went into the depth of what were the areas within that score that they did well, and those were the areas that they did not do well. And we presented it across various, again, what was presented as part of the framework. So for example, city disaster response score, scene ICS score, and I just wanted to just show you scene ICS is clear position and role of security officer. If it didn't happen, then the city scored poorly on it. Similarly, hospital triage and treatment score. I'm just showing you pieces of what we have. We have a lot more data for every city. Hospital safety and security scores. And then on the management side, clinical care scores, for example, had a lot of other detail available for clinicians to look at and make some decisions on what they can improve in their own respective areas. And at the end of the day, we made these recommendations to, say, a city. We went and we said, the overall performance shows that there are critical gaps and you have a score of 45. And we also shared with the city leadership what can be done based on their scores. So what policies and procedures need to be done? How do you strengthen a structure? How do you strengthen this in command structure? And how do you resource manage? So the point is that we didn't only diagnose problem, we also gave, and under each one of them, there is a lot of detail for the policymakers and others on exactly how do you solve that problem. Last couple of slides, the limitations for our approach is very early in the development phase. We only have validated in 2 cities, as I showed you. We have partially done in a 3rd city. We use disaster drill as a gold standard and not actual disasters because it's so difficult to get data during that. It is a diagnostic and intervention tool, but then you have political will and governance and local capacity that were only partially captured, not completely. Our future directions, we like to further analyze and publish. Of course, that's part of what we do as academia. We would like to do more validation, reliability test. Hopefully, we're thinking about 10 cities so that we are more confident on our finding. And then finally, in the next 6 to 9 months, again, thanks to the ICRC friends and headquarters, we're going to create a website. We will automate the data collection and analysis, and harmonize our guidance to the cities. And then in the next couple of years, we hope to look for funding for validation in a few more cities. My thank you for many of my partners in this, and I will stop here and take any questions later on.
Thank you, Dr. Junaid, for your presentation. We'll go right to the next presentation. Philippe, over to you.
Yes, thank you. I'm just about to share my presentation. Up. Can you see the slides? Yes. Okay. So let's start. So I'm going to introduce to you, it's especially, I see a link between the presentation of Dr. Junaid and what I'm going to present to you, because it's maybe the next step after the assessment of what we can do, share, and all the things about the resources in a city. The presentation of the Merci project it's much focused on the organization of organizations like the Red Cross. So just to start, just to recall that in the context, since the beginning of the century, the multiplication of catastrophic events, especially the new type of risks on the European context, made us think of some measure to take and to share with cross-border countries, especially to fight against climatic changes and all the results of that changes and terrorist attacks in urban city. So the thing is that we have to share the complexity in terms of coordination of our organization, just to better serve the population when something happens. So the objective of the project is to develop a replicable, transnational response planning tool, and to strengthen the capacity of civil society and volunteering civil protection organizations, increase their efficiency in the field of multi-site or multi-risk event management. So this project has been made with, in partnership with the Portuguese, Spanish, Italian, Bulgarian Red Cross and the EU office of the Red Cross in Brussels. The project has focused on five items: the state of art, about the coordination and response interventions to multi-site and multi-risk incidents in Europe. So that part was made by a university with which we have made a partnership, because we need a laboratory to take the data and to reveal what what exists and what we can take about that subject of multi-site, multi-risks. And in fact, we measure that nobody has really written anything about that. The second item was study the protocols and procedure of partner countries to see what are the meaning with which they respond to catastrophic events, especially in urban areas, and the multi-site, multi-risks at the same time. We have developed a manual of procedure for management of that kind of events, multi-site, multi-hazard, and multi-risk. And after we have made we have built a workshop about capacity building process, how we can strengthen the capacities of the answering and the response of each national society, and how we can manage that. And after most case simulation exercises, just to train and to see what can be the real thing to do, and maybe things to be right on time and right on the event, in fact. So what is a multi-site, multi-risk disaster? Multi-site and multi-risk events are different events occurring very closely in time, few hours of time, in different affected areas within a limited perimeters. So as you can see on the slide, we have a lot of things like in different cities, the safe cities, or in metropolitan area. All is studied with the same attention, because we know that the complexity of the context should be the things to look at very closely. So after, you can have massive attacks, terrorist attacks, but you can have a terrorist attack and after an industrial event or anything. So it's always urban areas and a lot of 3, 4, or 5 events at the same time. So why Mercy? Why we have? Why did we think of that subject and that project? Only because we have a plan here in Paris, a protocol called Aramis. Aramis as the character of the Three Musketeers. That means that we have action coordinated on a multi-site, multi-risk events with specific intervention, if we translate in English. And the thing is that we have activated that plan for the terrorist attacks in Paris in January and November 2015. So we have measured and assessed, and we could assess the reliability, the capacity, and the capability of the plan. So if I show you on one slide, the thing is that you can have three, for example, three events. And the thing is not to bring all the resources inside the perimeter, security perimeter, but in fact to put all the resources outside the perimeter, and after to have a coordinated action just to send the resources where they are needed. So that's the point of the Mercy plan, Aramis and Mercy plan after. So what can it brings? In fact, it can bring that effectively, if you have terrorist attacks only in large urban zone, you can have it's the same model of treatment. In fact, you can have different events, but it's the same treatment. The thing is that if in two countries you have the same protocol and the same intervention goals in managing the resources of the national society, the thing is that maybe you can speak the same language, but you can have the same lexical. So with a transborder problem, it's easier after if you have the same protocols to strengthen, to help the other national countries if it's just across the border, or if only 20 or 50 kilometers far. So that can bring a real, how to say, augmentation, increase. It can increase really the efficiency of mutual intervention in the transborder problem. So involvement and missions of voluntary civil protection organization in crisis management are a point of discussion actually in Europe, for example, at the European Commission, because they are here to support the public authorities by filling the gaps. We have talked about gaps in the early presentation, but the thing is, it's real because we can bring some more resources. In the different phases of crisis management, we can bring things too, because the thing is not to just have an intervention on what we can call hot zones, but also in collateral events in link completely with the hot zone of the hot events. For example, terrorist attacks. You can cut off the train circulation, all the things like this, and you have people trapped in trains, and after a few hours you have to do something with those people, or a lot of things to do. So the Red Cross can have a lot of intervention, different intervention. That's why we have a thought of how we can manage all that, just to have an efficient response to all the solicitations. And after new crises that means new management, new vertical and horizontal management, and all the things. We have to change the methods, and we have to learn to be surprised now by the events, because we have to plan things, but we have to leave a little part of reflection, just to be not to be very surprised, but to have a chance to be surprised by things and to accommodate the response. And as you can see, you have to develop a culture of risk, because that's something is missing in Europe, not in each country, but in some one, because people have the habit of getting answered by authorities or public services, a lot of things, but they can bring too an help to resolve the situations if they are prepared to answer to that. So the presence of efficient voluntary civil protection organization in a territory is also a factor of resilience for all the population and all the country.
We have 3 more minutes at this point. Thank you.
Okay, so I'm trying to be quick. So we have to success in the development of that kind of project. You have to write or to implement guidelines with first protocols, how to become a complementary element to emergency plan. So it's only organization part, to define the operational procedure to respond to that, to delineate the terms of engagement and the means of coordination of your organization or organization of the Red Cross, for example, prepare the mobilization of the resources, and review or complete the emergency procedure or local operational plans that exist. So 3 phases, very important, because they are really the hardware of the thing. The preparation phase, you have to check your alarm system. The awareness of volunteers and staff too. That means training and all the things. After the intervention phase with alert and activation, I can do that. I can do that if there's no phone, there's no communication. Operation management, how am I organized to lead and to manage all that? The resources, what are my resources, what I can are my resources locally in my town or in my urban area, and maybe what can be bring by the others, and the communication, the security of all the actors, and in 3, the phases back to normal. I can from a crisis moment or a crisis event, I go back to normal life. And the difficulties we have found in ending multi-site, multi-risk incidents, the number of situations that need to be really tracked and done in the same time. How can I manage all that? The fact that any organization has a limited number of accident commanders and not necessarily all available. So how can I lead my organization? The dimension of isolated events, often too small to need a disaster emergency or crisis manager to coordinate things, but too large to be managed correctly by first responders alone. So how can I manage that? By training maybe the responders, and the potential danger for volunteers operating in that type of intervention. So after, just to finish, the capacity building by training, the instructors, and after you have different phases, but the instructors, after the trainers, and after the commanders and the responders, making exercise really, and assessment at every corner of the situation, just to be efficiency and the more efficiency relevant possible. Okay, thank you. I hope that my English has been understandable. Thank you.
Thank you so much, Philippe. Thank you for this presentation and the experiences from your side. Dr. Shawky, over to you.
Thank you, Isabelle. I'm just waiting to share my screen. 1 second.
Qu'est-ce que j'ai fait? Ah merde, je me suis coupé. Tu as coupé le son? Non, non. Ah, le son? Non.
Can you see my screen now? Okay. So first of all, I want to go back to how Isabelle started this session, because I just got my memory back to August 4, which is the day that we will be presenting in today's talk. And those scenes that she described are actually what Lebanon and people who lived in Beirut experienced on August 4. And this presentation, which will be covering 4 different sections of, or 4 different sections, we will start first of all by discussing the context and background in which the Beirut port explosion took place. Then we will move to the next phase, which covers the emergency medical services or the immediate response to the blast. The third section will cover the post-acute response to the blast, and the fourth section will cover supporting existing structures as well as the learning that was done. So just a brief description of the context and background in which the blast took place. So the Lebanese Red Cross works in Lebanon mainly via 5 operational sectors. These are the emergency medical services that provide the main pre-hospital services and transportation of sick and injured in the country. Blood transfusion services, and again, the Lebanese Red Cross is mandated by the Lebanese government to provide the EMS and the blood transfusion services in the country. Disaster management sector, which provides services related to water, water, sanitation, hygiene promotion, sheltering, and basic assistance. And the medical social sector, which provides services related to primary healthcare, in addition to the youth sectors, which includes a lot of clubs and universities and different areas. So on August 4, 2020, at around 6:08 in the afternoon, a mass explosion hit the Lebanese capital, Beirut. And this explosion is reported as one of the biggest explosions, non-nuclear explosions in the recent history of mankind, resulted from ammonium nitrates that were stored in one of the warehouses of the airport. As a result of this explosion, thousands of people across the Lebanese capital were injured, with hundreds killed and missing, and shattered glass that were reported miles away from the site of the explosion. The video that I'll be showing right now shows some footage from the day of the explosion. And the animation that I'm showing right now shows the shockwave or the pressure wave that was created by the explosion and the area that sensed this pressure wave, which is, as I mentioned earlier, miles away from the site of the explosion. So as a result of this explosion, we had 200 individuals dead, more than 6,500 patients injured, 86 missing, and more than 300,000 people suffering from losses and home damages. The aerial and satellite images I'm showing right now show the site of the explosion before and after the blast. You can see the amount of damage that resulted and the change in the topography of the area that was affected by the blast. However, at the time of the blast, Lebanon wasn't only responding to one incident or one explosion. We were responding to a series of crises that were overlapping. So to start with, Lebanon was still suffering from an ongoing refugee crisis. At the time of the explosion, we had more than 900,000 refugees registered, accounting for almost 200,000 households. And as you can see in this table, Beirut had around 23.4% of these refugees. Similarly, Lebanon was experiencing an outbreak when it comes to COVID-19, with at that time, we had around 2,300 cases per day, which added also to the complexity. Moreover, Lebanon has been suffering from a socioeconomic crisis whereby the Lebanese pound has lost its value dramatically, and the economy has almost collapsed, where people lost access to basic commodities such as electricity, fuel, medications, and this also resulted in a lot of road closure and protests all over Lebanon. So all these together were the context in which the blast took place. Moreover, to add to the complexity of the situation, the main vital services that provide healthcare services to the community were affected by the blast itself, and this is exactly what Isabelle gave as an example in the opening. So we had 4 dysfunctional hospitals, 2 partially out of order hospitals, 2 affected hospitals, and 1 hospital actually required immediate evacuation at the time of COVID. And this hospital, now we would see the pictures, is a university medical center and had a COVID unit dedicated to COVID patients. We had more than 8 healthcare centers completely damaged and 49 healthcare centers affected by the blast. So how did we respond? Again, this was not a remote village in Akkar or in Beirut. This was the capital. This was Beirut at the rush hour at 6 p.m. in the afternoon. The Lebanese Red Cross had to activate its emergency response plan. And it was really crazy during the first few minutes. It took actually around 20 minutes just to be able to locate the site of the explosion, because dispatchers were receiving calls from all over Beirut, and each street actually claiming to have the explosion taking place in their exact vicinity, which is because of the amount of damage that happened in all these areas. Immediately, more than 75 ambulances rushed to the site. The number increased to 125 ambulances within the next 2 hours. We were able to treat and transport more than 2,000 patients. 6 blood banks were put on alert, and more than 1,500 blood units were donated during the first 48 hours. This is the site map. So this is the site of the explosion. We initiated 2 forward points in order to provide triage and treatment of the casualties, especially that many of the hospitals that we mentioned earlier were actually damaged. As a matter of fact, one of our emergency medical service stations were affected. The hospital right here, St. George Hospital, was majorly affected and it required complete evacuation. Hence, we established command and control at 3 levels at the emergency dispatch center in order to command. So we had 3 levels of command: strategic, tactical, and operational. And we tried to maintain a unified command for the Lebanese Red Cross at a time where the country lacks actually a unified command structure, which had to mobilize resources from all the way from the north or the south. And again, these people were driving in the roads of Beirut for the first time. And this was also another challenge. We had to resort to look for alternative sorts of communication and coordination. We identified the importance of having data and data being visualized easily, and having a lot of people who can filter data for the commanders in order to make evidence-based decisions. And here we also appreciated the importance of implementing our preparedness plan, and we identified the importance of the time spent in doing trainings and simulations for our staff. And accordingly, following the blast, this is the main, these are the main lessons that we learned. First of all, when it comes to any incident, any mass casualty incident at this scale in an urban setting, we know that the number of casualties decrease with time at the site. However, we also know that there is a lagging period between the time the emergency response services start arriving to the scene. And this follows a bell curve. And accordingly, we identified that in any mass casualty incidents, you actually have 4 phases of the response. And instead of spending time trying to organize the space, the geography, then we identified that commanders need to move into temporal or scene organization to organize the timeline of the incident. And accordingly, we identified 4 different phases. The first phase is the phase where you have very high number of casualties and very low resources. The second phase is when you mobilize your resources and you still have very high number of casualties, but you still have high resources now. The third phase is where the number of casualties is low and the resources is still high. And then that's the final phase is when you have low casualty and low resources at the time. And this is the order that things happen. And accordingly, through different phases, different things should be done. So during the first phase of lack of resources, your focus should be on establishing forward points, providing triage and basic first aid. In the second phase, which is the phase of surge of resources, that's the time where you should invest in transporting casualties, because that's the time when you have enough access to these casualties. During the third phase, the stand down phase, this is when you do your interfacility transfer. And finally, during the last phase, which is the normalization phase, this is the phase where you can support search and rescue efforts and do the management of the death. So how do we apply this in real life? In real life, we understood that each one of these phases requires a separate commander. And that's why you have commanders at 3 levels, sorry. So bronze commanders, those are your forward operational commanders that are present on site, and their main duty is to manage the space. However, the tactical commanders, these are the most important people in such incidents, because these are the ones who manage the timeline. And as I said, you can't have one commander. Instead, you need to have one commander dedicated for each phase with separate resources in order to be able to do it. And finally, the strategic commanders, these are the ones who manage the relations and the PR. So main challenges that were faced during the early phases included challenges related to access. Again, this was Beirut at rush hour. So hospital capacity, things that we take for granted, such as our biggest tertiary hospitals were destroyed and actually required evacuation. Communication lines were lost. We lost a lot of records. Many of the patients were, we had no records for patients, neither in the pre-hospital setting nor in the hospital setting. We didn't actually expect, and this was the unexpected in terms of scale and in terms of such type of explosion happening at the same time while we're facing a pandemic. And finally, we identified the need for a dead body management or mass fatality plan in Lebanon. So the main lessons learned in terms of pre-hospital care are related first to command and commanders, choosing the right commanders to command such incidents, training them well, sticking to doing the no harm approach, instead of having very strict procedures that don't work in times of crisis. We need to teach our commanders to have critical thinking, to make decisions relying on that, and to stick to standards while trying to bring order to face and while trying to think ahead of what could happen next in order to anticipate that and work on it. This is a testimonial from the Chief of Staff of the St. George Hospital that was evacuated, who salutes the work of the Lebanese Red Cross, and another testimonial from one of the people who were affected by that time. In the post-acute phase, also so few hours following the explosion, the second day, we started mobilizing our mobile medical unit, to activating our primary healthcare services and providing psychosocial support. As we move to the post-acute phase, to the disaster management phase, we noticed again that this is Beirut, this is urban setting. We can't just do normal WASH activities. So we had to divide our response into 3 phases. The first phase, we start providing ready meals, doing sheltering, psychological first aid and assessments. And the second phase, we started doing in-kind distribution for a couple of days until we set up the biggest intervention, or the biggest part of this intervention, which is our cash response. So we provided 1 month of emergency cash and 6 months of recovered cash. Again, because this was urban setting that we were talking about. You can't, so if you want to preserve the dignity of the people, then you would calculate their SMEB, provide them with the cash, especially with a place like Beirut where you have a well-functioning market, and then they would get the assistance that they need. We also provided shelter rehabilitation, either directly through contractors or indirectly through cash top-ups, and we work on the livelihoods. We ended up providing emergency cash for around 11,000 households in Lebanon. So What did we learn? We learned to invest not only in the first 72 hours, but to invest in post 72 hours. We learned to invest in emergency preparedness. We learned to build on what we have and to revise our command structure and to enhance the strategic and operational understanding between the different levels in the Lebanese Red Cross. We identified and appreciated the importance of data and importance of information management. And we appreciate, or we understood that people are key. Context is king and people are key. So we need to listen to people and understand the context and make sure that everyone does in any response. The final phase is disastrous reduction. We do know that in any response, the community are the first members are the first responders. We are always the second. So we also supported the forward emergency room that was led by the Lebanese Armed Forces by the daily operation plans, aligning the NGO's initiatives, providing logistic support, coordinating the application of COVID response, helping in data management. So many dashboards like the one I'm showing right now were created for the emergency room. We also work on enhancing community engagement by supporting Mount Lebanon governors, identifying key responding stakeholders, setting operational plan, liaising responding entities with governmental institutions, and providing required technical support and tools to the community. The response ended as a matter of fact, but that was not enough for us. So we had to identify all these lessons learned and to change our response based on what happened. We learned, for example, in terms of community engagement, the importance of engaging community in the early phases, the importance of adoption of digitalized systems, the importance of coordination between local, international, and governmental entities, the importance of preparedness measures in response for improved response in times of crisis, and the importance of building pre-existing structures. However, in order to document these findings, we conducted a real-time evaluation for the response that was conducted by an external evaluator, which identified the gaps and the challenges. Accordingly, the Lebanese discarded the review of the Lebanese Red Cross new strategy, which was updated last week, as well as the emergency response procedures in order to address the gaps that were identified in these challenges and to build on the best practices and the lessons learned that were identified from this response. Thank you.
Thank you very much, Shawky, for this excellent presentation, and thank you all for your presentations, which showed us several sides of what it means to respond in urban areas and to prepare for these kinds of mass casualty events. We now have the room open for questions, and you can please post them in the chat if you want. And I would like to go back to our first presenter, first of all, Dr. Junaid. We have one question in the chat from Chart that is going into the point that you mentioned. Actually, the gold standard now, if I understood correctly, is a simulation, but past events have not been taken into account until now. So this is exactly the question of our participant. Are you also considering to look at the past events in a certain city where a camera tool has been used and use this assessment also to validate your findings up until now? And one thing, Shawky, please discontinue the sharing of your screen. Thank you. Over to you, Dr. Junaid.
Yeah, thank you so much. This is a really important question. And I agree with the person who asked the question that eventually our tool will have to be validated against the actual response. The problem with past response is that when we looked at how good the response was, there's such a lack of often critical data and such a non-uniform collection of data that we can't do it. But moving forward, eventually, if we do have a mechanism of collecting a unified data, then we can compare our tool to that.
Thank you very much. I have one more question for you from my side. Now, you mentioned a bit what is lying ahead. Okay, further analysis, and then also the question if other cities are interested. Obviously, funding is a question. If I was elected mayor of Berlin tomorrow, and I'm interested in camera tool or for that matter of any other city. What would be the approach, or what are you aiming for in a city to look at to fit a certain portfolio? Now you have 3 cities already under investigation, so to say. What would you be looking for? And after that, if you have the room also to pose a question to your co-panelists. Otherwise, you can pass the ball back to me.
Sure. No, if you are the mayor of a city X and want to understand how your city is used, how is city prepared for mass casualty event, the approach will be, what has worked for us is we partner with a local academic entity, a university, somebody who has an interest in science of research of disaster, will train their personnel on how do you collect the data and who are the people that will collect the data from. The data is collected on a Qualtrics model. So it's a conversation between data collectors and the people that are giving the data. There'll be some visits to some key places. All of that information is put in a database, and you will get the kind of charts that I was showing on the scores. And hopefully, as mayor, you'll say, okay, now I've identified where we are and what our gaps are. Let's work on it. I would like you to come back in 3 years and see what our score is today. And that's how you will gauge your own performance over time. I don't know if I answered your question.
Thank you very much. I believe, yeah, definitely the cooperation with local academia is key. Would you have another question for one of your co-panelists at this stage?
Yeah, I wanted to ask Dr. Shawky, Amine. So I wonder, having worked with multiple agencies and countries, sometimes the state, the governments, other NGOs don't like the fact that one non-government entity is responding. And that becomes even more difficult when the state is unable to provide that response. And then they also don't want to give up that power of response. How do you manage that in your setup? Is that a problem? And how do you manage that?
So I will focus the answer to this question mainly on the pre-hospital context, or the pre-hospital services that we provide. So when we talk about Red Cross, Red Crescent national societies, there's this very specific auxiliary role which the national societies have, which puts them in a place where they are not completely non-governmental, yet they are not governmental organizations, and which we actually makes the government request specific functionalities from the national societies. In Lebanon, the Lebanese Red Cross is mandated actually by the Lebanese government to provide emergency medical services and blood transfusion services. However, the whole, a policy review was done, as a matter of fact, a couple of years ago about the pre-hospital care in Lebanon. And as a matter of fact, there are no laws in Lebanon to organize pre-hospital services. And the pre-hospital system is very fragmented, which requires one of the entities, a strong entity, to take over such events. However, in times of crisis such as the Beirut port explosion or the multiple crises that we had been responding to, there's a lot of challenges and difficulties when it comes to coordinating with other actors, especially that we have many different actors. So it's true that the Lebanese Red Cross is the main actor. However, we have many other pre-hospital healthcare service providers, and coordination in the absence of a unified incident command system becomes really hard. And again, this is one of the challenges that has been identified by us, and even as well by the external evaluator who did the evaluation of the Beirut blast response.
Thank you very much for this question and your answer, Shawky. There is one question from Philippe. Maybe you want to pose this to Dr. Junaid yourself. Please, Philippe, go ahead.
Yes, I just want to know if the camera tool is adapted for multi-risk, multi-site, and multi-hazard events in a city, and in the way you presented it. I thought that it was only for one special and big event, but is it adapted to have a focus on 360 round?
Yeah, that's a good question, and thank you for asking. On the EMS side and in the security side, when we ask questions, we have a few questions around what would happen if you have more than one event. I think based on what you were talking about, we can look at how deep does it go, and if we need to improve on that. But that's we have tried to address it, but probably not as deep as what your experience has been.
Thank you.
Thank you very much to both of you. There's one more question from our participants directed to Shawky with regard to do no harm. You have mentioned that in your presentation. In what regard was that important? Was it for onboarding volunteers during the event, or what level or what role did do no harm play? You're still muted.
Sorry. So thank you for the question. When it comes to doing the do no harm approach, we all know this is probably one of the main things that we take into consideration, whether we're providing medical services or even when talking about mental health. However, in times of crisis, sometimes we tend to oversee this main principles. You know, in times of mass casualty incidents, especially when you have a lot of patients, sometimes you have to withhold your services because the way you approach mass casualty incidents is very different from the way we approach patient care in normal cases. So when you have one patient coming to an emergency department, you would have tens of nurses and doctors providing all the services and putting in all the resources that they have, trying to save that one patient. However, in times of mass casualty incidents, then the golden principle becomes doing the best for the most using the least resources in order to try to save as many possible lives as you can. And while trying to do this, sometimes you will try to, the amount of services that you are able to provide becomes much less due to the lack of resources. So that's why one of the main principles is trying to maintain this do no harm approach, and then not only at the level of the patients and the victims of the incident, but also at the level of the rescuers who themselves are put under a lot of pressure, especially in the situation where COVID, where the blast took place, where people were responding to COVID. We knew at the first that this was a chemical explosion. We didn't know what the exact material was until it was actually an hour and a half following the explosion. So all these things are things that we need to keep in our mind when making decisions or when commanding such incidents, in order to protect the beneficiaries, the communities, the witnesses, and most importantly, our staff and volunteers.
Thank you very much for elaborating. If you allow, I would stay with you for one more question, because as I understood, obviously the backbone of the success of this work for LRC has been the well-trained staff and volunteers who were able to adapt in a situation where also a lot of technical solutions have failed, networks were down, and so on and so forth. On the other hand, you're showing a lot of apps and dashboards that have been developed. So maybe you give us a bit of your perspective on all these apps, because everybody nowadays say, okay, let's have a dashboard, let's have an app. For whom was dashboards or apps useful in what stage? This is my question.
Thomas, I come from a medical background, and I commended the EMS component of the service. I will be very straightforward, and I always say this to our staff and volunteers. In times of crisis, by now, we know that technology can and will fail us. And we, especially during the first few seconds, the first few minutes when you need to make the big boys decisions, whether you enter a scene or not, you cannot, we weren't able to fly any drones to do an aerial assessment during the first few minutes because the fires were huge. We didn't have access to electricity. The electricity lines went out. The telephones went out. So during the first phase of the response, and that's why I always divide the emergency phase from the post-acute phase. You need the most basic tools in order to make the decisions, and that's why we train our all our commanders who command EMS services on the command framework, which is the framework used at the Lebanese Red Cross, which can be done on a paper, on a whiteboard, and it can be recorded at time. And we try to take pictures with phones just to keep records. And this is the most useful tool that has worked for us during the protest, during the explosion, during the wildfires, during all the crises that happened. However, during the post-acute phase, when you need to do the multi-sectoral needs assessment, where you need to build and implement a huge response that includes shelter response, basic assistance, cash, water, sanitation, hygiene, promotion, then you need to maintain for your own transparency, for your credibility, and in order to be accountable towards your beneficiaries, then that's the point where you need to rely mainly a lot on technology. And these are the main dashboards that we show. So these were one of the dashboards was related to the assessments that were done, identifying the needs of the different beneficiaries. Another one was used in order to coordinate between the different NGOs that were providing services in order to provide work duplication and ensure coordination. And then we had one dashboard for each sector. So one for WASH, one for shelter, in order to divide the areas for people working under the same sector in order to ensure coordination. And this is exactly where technology would be great and it would work and it would help, but definitely not within the first few minutes of the research.
Thank you very much for elaborating more on this and delineating where technology is adding value and where sometimes it or often it fails us. I would switch now to you, Philippe, with a couple of questions. So when we're learning from Aramis's project and looking at the Mercy project, what would be interesting for me is when we're looking now, for example, at a cross-border cooperation, when we have one situation that may be affecting both sides of the border. Obviously, we're having a conference here on disaster risk reduction in Germany and Europe, but also internationally. The authorities and the administrative burdens often are somewhat high. So what steps could you take through this project, working together with also the colleagues from Portugal and Bulgaria and France and in Spain to see, okay, we speak the same language here and we can align some of our protocols. What was the successes and what was also the difficulties for you in this?
Thank you for this question. It's typically one of the most important questions around that project, because the thing is that first it's really a matter of knowing well his organization. So what I mean is that, for example, at the German Red Cross, if you want to you say, okay, we have protocols, we have procedure, we have a lot of things, all the process are known, everything is all right. But if you really think that it works, okay, it's okay. But the thing is that maybe you have to think of what can happen if you have to answer, to respond at 3, 4, 5, or 7 events in the same time in burning area, for example. That means that you have to consider all the things, the solicitations that you you're going to have from the authorities for this and that and all the things, social, psychosocial support and medical social things and maybe the blood and maybe all the things in the same time. So you have to command all the things in centralized commandment. And you have to think of, okay, we have that, we have a lot of resources, we know our resources, maybe a lot of our resources are completely impacted by the events. So at what time will I ask the resources from outside Berlin to come and help and all the things like this. So it's a very big thinking, reflection, work on how can I manage my organization in case of chaos, in fact. That's the point. After that, you have to think, okay, at what time the French will come, at what time the Spanish will come, and all the things. Maybe it can be funny to think at that, actually, but it's a real thing. For example, in Paris, we have the main risk we have is flood. We are waiting for every 100 years, we have one flood in Paris. So we are waiting for, and the thing is that all the resources in Paris, public services, the fire brigade, all the medical teams and all the things, we know that they will be completely exploded by the impact of the situation. So how can we manage to have resources from the outside, and how we manage that? How can we manage first, and after, how can we manage it inside, within the events? So that's the point of the basic reflection of the Mercy project. After we made exercises with the different national societies, but we never tested cross-border things, actually, because, you know, in Europe we have the problem of the agreements, the state agreements for civil protection. We have in the 27 countries, we have 14 countries who have a special law for intervention in a catastrophic situation. So maybe that's the point where we can say, okay, we are the Red Cross, we can strengthen each other. So maybe we can have an European agreement for that. It's what we are for, but it's a wish. But the thing is that actually we didn't test, we didn't assess it. We don't. We have no test about what we can do between I don't know, Strasbourg and a town in Germany, for example. But the thing is that if we have the same lexical, it will be more easier after to manage all what can happen, because we know that as we are the Red Cross, we as our Lebanese colleague said, they are asked for everything in every way. So we very have to think of what we can really give and how we can give it the more efficiently possible. And I think I answered to your question. Yeah.
Thank you very much. I have one more question, a bit similar to the question earlier to Shawky, where we were talking a bit about technology. Here, also one asset, obviously, of Red Cross and Red Crescent globally is the volunteers, and we have seen in every situation where we had unforeseen events that there's a surge of volunteers who are not prior associated to the Red Cross, but also the volunteers who have been associated with Red Cross, they would call and they want to support again. So my question is with regard to big scale events, what is the role of the volunteer, and what is also the role of volunteers in the days after when they come in, and how are they utilized and how are they supported, both?
Thank you, Thomas. So when it comes to the Lebanese Red Cross, let me stratify the volunteers into 3 types. So first of all, we have the experienced specialized volunteers. These are volunteers who are trained to perform a specific set of tasks. For example, our emergency medical technicians, we have more than 4,000 volunteers. Our disastrous reduction volunteers, our disaster management volunteers. So these are volunteers who have attended a lot of training curricula and followed specific career paths in order to be able to perform specific tasks. And these are the volunteers who are at the front line of the response, actually leading the response. The second group of volunteers are the surge capacity. Surge capacity are people that are usually in the youth sector or in other sectors and sections within the Lebanese Red Cross who attend a basic surge capacity training. And in times of incidents like this one, they are called upon to support. So for example, going back to Beirut blast, the surge capacity was actually supporting and doing the assessment and doing the distributions and doing the basic tasks, again, under the lead of the experienced volunteers. The third type of volunteers, and these are an actual asset that we need to take into consideration, are the community volunteers. So whenever there is a big incident like this one, it's very normal to see a huge surge in the volunteering capacity. And this is the first time that the Lebanese Red Cross actually managed to do this with because of the Disastrous Reduction program, which is very strongly supported by the German Red Cross, whereby we were able to work on community engagement and build on pre-existing structures within the governorates in order to organize the work of these people, provide them with the precautions, COVID awareness sessions needed, provide them with the tools needed, guiding them so that we avoid duplication of work, and telling them where to go so that their volunteer effort would actually matter and count into the response. And this is a very important area that it's a huge opportunity that we identified following the blast, and we are willing to invest in for the future because, again, in times of crisis, these people are really important and they provide a huge source of resources that can be mobilized in order to work and in order to support and responding to crisis.
Thank you very much. I think Isabelle has another question. Over to you, Isabelle.
Yeah, maybe a last question to Philippe and also Shawky very briefly. I think you can maybe answer it briefly. I come back to this scenario of the worst case, or this unexpected scenario in preparedness. I think we all said that yes, it's possible to prepare for large and complex incidents in cities, and we must. But I think there's always like kind of a gray zone in terms of like preparedness, like how much can you prepare for this unexpected event? Maybe just very briefly, Philippe, what would you tell your staff or your volunteers from your experience about this gray zone? Like how do you raise that unexpected event in preparedness?
Yeah, thank you. We have a policy from now more than 10 years about the fact that every volunteer should be trained at we have 2 levels, as you have understood. We have 2 levels of training, one for responders and the other for commanders. And almost all the volunteers of the French Red Cross are trained to respond. And as usual, you can be trained, but if you never meet the situation, can be no efficient. So the thing is that we organize, or we try to organize exercises and simulation training as often as we can to make the people keeping their skills around the response of what I can do alone, what I can do with my team, and how could I react if I meet that kind of situation, because that's the situation that we met before. So we have the experience of that, so we can adjust the training around that. So that's the point for every volunteers, and we have a group of top managers. We have 40 or 50 persons all around the country, and they are trained to go and to take the command in that kind of chaos or complex situation when nothing is going worse, especially because all is impacted by the events.
Thank you very much. Shawky, what do you give your volunteers on the way? In 1-2 sentences at the end.
Well, it takes a system to be able to respond. It's not actually one training, it's a system that allows volunteers to be trained in order to respond. And once the different components of the system start talking to each other at the same level, then I think we are ready for the next disaster.
Thank you very much. And I think this is a very good final word, a call for support to the volunteers who are the backbone of our organizations. I want to thank all of you, first of all, the participants who shared their time, and also obviously our great panelists who have given us a great insight into mass casualty work in urban areas, how to assess them and how to work through them, how to take the learnings forward, how to support also with these learnings other national societies, as this session itself is a learning opportunity for all of us to see what has been done all over the world. And I wish you a very good conference on DRR ahead, to join the English sessions if possible, and want to thank you and wish you a good evening and afternoon. Bye-bye.
Bye.
Thank you very much. Bye-bye.